So guys, we can't finish talking about long complications of long bone fractures if we have not spoken about compartment syndrome. Let's talk about compartment syndrome. So we've spoken about we've spoken about fat embolism. Now I want us to talk about compartment syndrome. Okay, guys, I want to tell you something. The main reason why we do not apply a full POP or a full cast on a fresh injury, the main reason why we don't apply a full POP but we apply a back slab on a fresh injury, an injury that is less than 24 hours, is because of compartment syndrome. So guys, never apply a full POP on a fresh injury. Fresh injury, an injury that has got less than 24 hours, even if it's less than, for me, even if it's less than 48, if they come in within 48 hours, I don't put a full POP on that patient. When you put a back slab on a patient, you have nothing to lose. Put a back slab, tell them to come back in 7 days for a full POP. If their fracture is a fracture that if it's a fracture that can be managed conservatively, meaning if it can be managed without actually operating. So it's because of compartment syndrome. We're going to talk about compartment syndrome now. So this is the main reason why we do not put a full cast on a fresh fracture. A compartment syndrome, remember, a muscle is like this. So let's assume this is our muscle. These are our fibers there. And this is our connective tissue that surrounds the muscle. I think it's called the epimysium. So what happens here is that when you are developing a compartment syndrome, you develop buildup of pressure within this muscle. So there's pressure build up. This muscle will try and accommodate the pressure that is building up inside that muscle. But it's going to get to a point whereby it cannot accommodate the swelling anymore, but the pressure will keep building up inside. When that happens, any potential space inside that muscle is used up, such that your nerves, they are squeezed. Your blood vessels are squeezed. When blood vessels are squeezed, then there's reduction and even complete blood flow. When blood flow is shut, then ischemia will develop. When ischemia develops, now it means you cannot supply blood to the rest of the limb. This is how you lose a limb from compartment syndrome. These guys can be squeezed. They will give you those needle-like pricking pains. If they are saved in time, they can still be fine. But if they're not saved, then they will die as well. Even the blood supply to the nerves, if it's compromised, without even the nerves being involved themselves. But if blood supply to the nerves is compromised, then those nerves will die. So what's going to happen is, people talk about the 6 P's, but this is how you diagnose compartment syndrome. So like I say, compartment syndrome is a buildup of pressure inside a muscle compartment such that there's compromise of blood supply and there's the nerves I'm looking for a better term than squeeze, but basically they are squashed. I'm sure there is a better term. Okay, so people talk about the 6 P's, which is pain, pallor, poikilothermia. Look this word up now, guys. It's not a word that we use often. So pulselessness, paralysis, guys, paralysis. 1, 2, 3, 4, 5. What P is my forgetting? Poikilothermia. I'm forgetting a P here, guys. Please look it up for me. Another P there. So if in order for us to diagnose compartment syndrome, we are gonna wait for paralysis, pulselessness, poikilothermia, pallor, we're gonna be too late. The first thing that we should do is to anticipate. In long bone fractures, we should anticipate compartment syndrome. An early sign of that we should be looking for, an early sign of compartment syndrome is pain that is out of proportion. That is out of proportion. I'll explain what that is. Pain on passive flexion. So pain that is out of proportion, if someone kicks you on your shin, you expect pain. You expect a certain degree of pain. But if now the pain that is actually the person that you kicked, if the pain that they are feeling is much more than the degree of pain that you expect, then it's out of proportion. You can't be kicked by a person and then you cry as if you were run over by a train. That would be out of proportion. It means something else is happening. So basically, that's what it means. So these people who are developing compartment syndrome, their pain is out of proportion, does not respond to even painkillers. The person will be crying, will be crying in pain. So another thing is, when you try and flex their fingers, they will have pain. So it's called pain on passive flexion. These are the early signs of compartment syndrome. You don't wait for this. Like, if in an exam they ask you about how to diagnose a compartment syndrome, you start mentioning this. Someone who's kind will still allow you to pass, but someone who's ruthless will not allow you to pass, because this is just problems. By the time there's pallor, there's pulselessness, there is a temperature what is it? If the affected limb has got reduced temperatures or is cold compared to the left. That's what it's all about, temperature differences between the limbs. So if you wait for that, it's already late. So pain on passive flexion, and this is what we should be documenting when we see this patient, that when we examined, there was no pain on passive flexion. The pain was within in a proportion. Yeah. So that's compartment syndrome. So why would a patient develop compartment syndrome from a cast? Let's say this is the limb that is broken. The fracture is here, right? Then this is the whatever limb it is. So this limb, they come in, they were hit by a car right now, and then they come in. We haven't allowed for the swelling of those muscles to take place. Now we come in and we put a rigid cast around that. So the muscles here will swell up. As they swell up, they will take this space, and then as they continue to swell up, they won't have any room to continue swelling. So what's going to happen is that you have created a rigid compartment around this. So the person will swell up inside, and then nerves are going to be damaged, blood vessels are going to be blocked, and then they come in with the compartment syndrome. So this is the reason why we wait for about 5 days to 7 days when a fracture is fresh, to allow the swelling to go, and then to allow the swelling to take its maximum effect, and then they come when the swelling has gone down. Another thing is that but the first one is the most important one, because they will come in with a dead limb. Because some people will stay with a pain that is, some people will stay at home with a pain that is out of proportion up until they come back, when nothing can be done, when they've got pulselessness, they've got pallor, they've got paralysis. So you don't want that. Another reason is that when you put a POP on someone who's still continuing to swell, that POP is not gonna, once the swelling comes down or goes down, that cast is going to be ill-fitting, because when you put it, the muscle was swollen, so it was tight at that time. But when the swelling goes down, it's going to be loose. So they come in, they can even start, they'll be walking even though they've got a cast, because it's ill-fitting. And also they can even actually convert their fracture to an open fracture, they displace it, and things like that. So you don't want that. So that's how you get. So what are the causes of compartment syndrome? It's pressure, guys. Assault can do this, like mob crash, like crash injury can do this. MVAs, like we said, PVAs can do this. Even bands can do this. So guys, it's very important. That's compartment syndrome. So as we're talking about long bone fractures, why would a patient who's got a long bone fracture develop compartment syndrome? One is that whatever that was hitting them can be, like I said, a crash injury. They're gonna get swelling of the muscles. That's one. Number two, they can snap a vessel, and then that vessel starts to bleed, and then there's blood collection inside that compartment, inside that muscle. That muscle will swell and swell up until it compresses the nerves and the blood vessels. So the trauma itself can cause swelling of the muscles, and also the bleeding of the muscle. Muscles, they bleed. They're very vascular. If you have never had to deal with a patient who's got a bleeding muscle, you don't want that, because a muscle is bleeding, even the vessel itself, is hard to identify it, just bleeding everywhere. So muscles, they bleed, they're very vascular. So they can bleed, and then blood starts to collect inside those potential spaces inside that compartment, and then they develop compartment syndrome. So guys, yeah, that's compartment syndrome. I'm not sure if I'm leaving anything out. One last thing that we need to do is, how do you examine for the Oh no, it's not in this video. It's not in this video. So this is it with long bone fractures, guys. This is it with long bone fractures. Thank you. Hi guys. So in this video, I hope you guys are enjoying this author series discussing long bones. I hope you're enjoying it. So I want us to finish it now. So let's talk about complications of long bone. I said long what? Complications of long bone. Complications of long bone fractures. So long bones have got, if there's displacement, there's actually a chance that one of the fragments can actually go on and pierce the skin, causing, so it's gonna be skin continuity interruption. So they can actually go on and cause an open fracture because of the fragment. Long bones can do that. Long bones can also actually pierce the vessels, and if they snap the vessels, especially if it's a major vessel, hemorrhage will result. Hemorrhage. There are two things that we are going to talk about that hemorrhage can do later on. So this patient can, two things can happen. They can go on into hypovolemic shock, and then death results. They can also injure their nerves. Long bones can do that. These are the complications that can happen immediately. Later on, other complications that can happen after a few hours, they can get fat embolism. When you've got a long bone, like we said, that long bones, they have got bone marrow in them. If you fracture here, it can actually happen that a piece of fat breaks off and enters the blood circulation. And actually travels to the lungs. And comes and dislodged in the lungs. So that fat droplet from the marrow that has entered the blood system, got into the heart, and then is pumped into the lungs, it actually comes in and block, depending how big is it. So it blocks one of the small vessels there, such that this area is not perfused. This is what we call fat embolism. So once that area is not perfused, this person starts having, they drop in sets, they become hypoxic, they become tachycardic, they become tachypnic. And if it's not picked up, this patient will actually go on and die. It's very similar to a pulmonary embolus, but the difference is that it's a fat embolus that does that. So long bones have got that. It's not something that happens immediately on impact. It can take about 24 hours, 48 hours, up until 72 hours. So there are other theories that this fat droplet can start to initiate some kind of local changes. There's an inflammatory response, but the main one is this, depending how big it is. And then this patient, it's going to be one of those patients that has been fine in the ward. They've been talking, they've been fine, nothing. Then at night they call you that the patient is distressed. The first thing that you're going to think about, are they having a PE? Because one of the complications of long bone is that once you've got a long bone fracture, you are going to be immobilized. So you're not going to be walking, you're going to spend all your time sitting on the bed. And that puts you at risk for developing DVT. And we know once you get DVT, you can actually go on and have a PE. Luckily, we have got Clexane for this. So you can sort of like give prophylactic Clexane, which is usually about 40. So, so when a patient that has been talking, all of a sudden, they will present as if they've got acute respiratory distress syndrome. That's how they will present, because this is basically that. So they will present like that. So if they call you in the ward, patient that has been talking, that has been well, they've got a long bone fracture, neck of femur fracture, long bone fractures, and then the sisters say the patient cannot breathe. Think about two things. Can't be thinking about pneumonia there. You can't be thinking patient's been talking. So think about pulmonary embolus and also fat embolus. So long bone fractures, 5, they will keep you in bed, so you are prone to have pressure sores. Long bone fractures are usually operated, especially if they are displaced, so you are prone to infection. Patients that have been operated long bone fractures, they are usually kept in hospital so for some time. So there's a risk of nosocomial infection, nosocomial infection, which can be UTIs. Remember, let's not put UTI, let's put UTI separately here. I was thinking about pneumonia here. We've got COVID now. Can even get COVID because you are in the ward, sitting in the ward, and other infections. When you've got a long bone fracture, you are like, especially if it's in the limbs, you are likely gonna get a catheter. That catheter predisposes you to UTI. What else? Okay, one thing that I want to talk about here is compartment syndrome. Compartment syndrome. That's why I said this can cause two things. Let's talk about this later on. Compartment syndrome. Actually, guys, so these are the complications that you expect with long bone fractures. Yes, you can have other complications like long-term, things like non-union, malunion, shortening of the limbs, chronic pain. Yes, you can have those things, but those are like your long-term complications of long bone fractures. So what I want us to talk about now is compartment. Oh guys, how did I? Okay, it's fine.